Hello, everybody. Thank you all for joining us. I'm Debbie Fox with the National Network to End Domestic Violence, and we're going to go ahead and get started. It's 1 o'clock here, and we have a lot to cover in the short hour. So just so everybody knows, we are going to record this webinar, so the webinar is being recorded. We want to welcome you all and encourage you to say hello, as many of you are, in the chat box. And please, if you have any questions throughout the webinar, put them in the chat box. And if we are not able to answer them in real time, we will do a follow-up email. The webinar is being recorded, so we'll do a follow-up email with the information from the webinar, along with any questions that we maybe did not get to or were unable to answer during this webinar. So everybody knows we're doing a webinar today on what you all, victim service providers and survivors, need to know about the COVID-19 vaccine rollout. We've been through a lot. It's about almost the year mark of when hearing about the first case of COVID in Seattle last year, and then we're coming around to the year mark of March, where many of us went into shutdown mode and where things really started to slow down, and we shifted how our services were being provided. So now we're at the point of the pandemic and COVID-19 where we're looking at the vaccine rollout. And as many of you know, people are getting vaccinated, and maybe some of you all here on this call have already been vaccinated. So we're at a hopeful place where we're trying to get the vaccine out to folks as quickly as possible, and hopefully getting it out to our advocates working on the front lines, and victim service providers, and also survivors who are coming into our programs and accessing services. So we are specifically going to talk about the COVID-19 rollout, get hopefully answers to any questions that you have about the rollout for survivors who are receiving services. We also specifically have presenters today who will discuss how to address vaccine skepticism as a result of historical and much and of course, much realistic skepticism about medical racism and neglect in marginalized communities, specifically in the African-American community and the Native communities. So we're going to just talk about how we can build trust with communities, increase access to the vaccine, and how we can get these resources to survivors so we can return to life where we are more in community and connected to each other in spaces that are in person. So at this point, I think we will go ahead and go through some of our slides. And I also wanted to do an overview of who our presenters are. We have Ashley Hesse, who is a senior consultant from Indigenous Pact. And then we also have Michele Williams, who is a HUD technical assistance provider and also works at a homelessness and DV agency, the Community Crisis Services Incorporated in Maryland, in Hyattsville. And then we also have Ashley Reynolds Marshall, JD, who is the Chief Executive Officer at the YWCA in Central Virginia. So we'll go to the next slide, please. So just a little bit about our work and who we are with the DV Housing and TA Consortium. So we're doing this work in partnership with a bunch of federal agencies that fund our work and support our work. So we're getting these resources from our federal partners and then disseminating information around best practices for DV housing programs and survivors who are in need of assistance as it relates to housing and homelessness services. So we are funded and supported by the Family Violence Prevention and Services Program in HHS, the Office on Violence Against Women at the Department of Justice, the Office of Victims of Crime, VOCA, at the Department of Justice, and also the Office of Special Needs Assistance, the SNAPS program at the HUD office with the U.S. Interagency Council on Homelessness. We also work in collaboration with a bunch of technical assistance providers. So I'm specifically with the National Network to End Domestic Violence, and we work with the state domestic violence coalitions across the country. I'm on this call with Jill Robertson, who's a part of Collaborative Solutions. They are a HUD technical assistance provider. We also work closely with the National Alliance for Safe Housing, the National Resource Center on Domestic Violence, and the National Sexual Violence Resource Center, and also the Corporation for Supportive Housing, that is also another HUD-TA provider. So lots of support for this work, lots of acronyms. So that's a quick overview of who we are. And then I think we're going to go to our infographic next, how we frame our work. We specifically are thinking about our work and the work of domestic violence and sexual violence, racism, and homelessness. And now when we're thinking about health inequities, layered on top of that, we center our work around those issues and the systemic barriers to housing that communities of color and LGBTQI communities have faced for the inception of our country and nation state. So I will, without further ado, have Jenny play that video.
And I apologize. It looks like this video didn't embed correctly into our webinar. So I'm going to put the link for the video into our chat, and maybe we can look at the next slides then return to it.
Okay, great. Thanks, Jenny. So a little bit more about our work and how we're thinking about COVID-19 housing and racial equity. So what we know and what we're seeing in terms of the disparities and health disparities, that there is systemic racism that's playing out with this health pandemic. I think specifically, I think about where I live in Washington, D.C., wards 7 and 8, people are dying at higher rates, much higher rates than wards where people are more economically advantaged, and there's systemic inequities. And that's also, we're seeing with the rollout of the vaccine, that communities of color, specifically like in the microcosm of DC as well, Ward 8, they're getting less access to shares of the COVID-19 vaccine. So these are all things that we need to be looking at when we are, oops, we lost the slides. As we are addressing the COVID-19 and the disparities that exist, and as it relates to housing and historical inequities in terms of access to healthcare and resources. And I have lost the slide, so I apologize for the technical difficulties we have. I don't know if other folks can see the slides.
I was just getting the video queued up on our YouTube channel, so we can go back to the video now, and I apologize for disrupting.
Okay, we're good. So I think we're going to play the video now, and then we'll have our speakers start after that. So, and thanks, so many people are on this call. We have over 300 people attending this call, and then it looks like our video is starting now. So thanks, Jenny.
Homelessness is an issue that far too many people face. People of color, specifically Black people, other persons of color, and Indigenous people, experience homelessness in a dramatically different way than their white counterparts. People who hold multiple identities, such as those who live at the intersections of disability, immigration status, sexual orientation, gender identity, and more, experience compounded barriers that further homelessness and housing instability. A recent study found that 66% of people experiencing homelessness were Black, while 28% were white. Black individuals are only 13% of the U.S. general population, compared to 74% of those who are white. Rates of homelessness within Native communities are 3 to 8 times higher than that of the general population. In total, 78% of people experiencing homelessness identified as people of color. This overrepresentation of Indigenous, Black, and other people of color experiencing homelessness cannot be explained by poverty or identity alone. Structural racism, historical policies, institutional practices, and cultural narratives that perpetuate racial inequity put people of color at a disadvantage in obtaining safe and affordable housing. Statistically, women of color are much more likely to experience domestic and sexual violence, and survivors often face network impoverishment. Network impoverishment occurs when the addition of a financially distressed household member places an extra strain on family resources. Oftentimes, we tell a survivor experiencing homelessness to go to a relative or friend's house. However, network impoverishment can cause immense burdens on the existing limited finances and available support from that network. Racial disparities arise at every juncture, from the legal system, to housing, to healthcare, to child welfare, to public benefits. Understanding the intersections between domestic and sexual violence, racism, and homelessness, and applying an equity, survivor-centered lens in our work is the only pathway to stability, safe housing, and healing for all survivors. If we want to address racial inequity, we have to acknowledge it, learn about it, and talk about it, so we can do more about it together. To learn more, visit safehousingpartnerships.org.
Thank you so much for sharing that video. I know there was a couple of questions about the video and where to find that. You can definitely share this video out far and wide as much as possible, as it's really critical information. It's on the Safe Housing Partnerships website, so safehousingpartnerships.org. And our partners at the National Resource Center on Domestic Violence were part of creating this infographic, so please share and use it far and wide. So at this point, we've framed the issue and where we're coming from in terms of increasing access and addressing systemic racism and racial inequities as it relates to housing and responding to COVID-19. And I think at this point, I'm going to turn it over to Ashley Hesse, and so we can get it started, and you can all hear from our amazing presenters who are doing really great work in terms of addressing these issues with communities and out in the field. So Ashley, it's all yours.
Thank you, Debbie. I really just want to say I appreciate this opportunity. For all of you that are here, thank you for your time and attention. My name is Ashley Hesse. I am Comanche and Apache descent. I currently live in Wisconsin, in the historic and traditional territories of the Menominee and Ho-Chunk people. I currently serve as VP of Policy for Indigenous Pact. Indigenous Pact is a public benefit corporation, and we are on a mission to create health equity for American Indians and Alaska Natives in one generation. We really work to achieve those goals by trying to increase healthcare funding and access to quality care on and off the reservation. So that really in and of itself allows us and provides us opportunities to work with tribal nations throughout the country to address these health inequities and disparities that you were just touching on in housing and all things that affect health. So my role with the VP of Policy, I get to look at a lot of big issues and big topics and try to find some creative solutions. And I'm very fortunate in that. And again, I just wanted to thank everyone for your time and attention and let you know that I'm here coming to you with a good heart and good intentions. I wish to convey my respects to all of us. It's a difficult work, difficult times, and we've all been deeply impacted by this current public health emergency. And I appreciate you all for being here and for your work. I want to kind of ground us in a little understanding and a brief background of Indian health services and Indian health systems, because I believe it might help inform your practices and possibly approaches to working with your clients and families that you're supporting, and maybe give you some thoughts and ideas about bringing additional resources and information to the conversations and challenges that you may be facing. For those of you who are not really familiar, Indian Health Service is an agency within the U.S. Department of Health and Human Services, and it is responsible for providing the comprehensive health care for 2.6 million American Indians and Alaska Natives who belong to 574 federally recognized tribes that are found in 37 states. Now, there are well over 100 and some odd state recognized, maybe I'm off my numbers, but there are a significant number of tribes that are recognized by states and not the federal government. So there's other things to know there and impacts of that. Indian Health Services responsibilities to provide the direct care to Indian folks through Indian health facilities, through tribal health facilities, contract facilities, and urban Indian programs. Now, American Indians and Alaska Natives are also free to take advantage of, other healthcare resources, including Medicare and Medicaid. And I really mention this background because it's important to point out the federal responsibility. I believe it is important to point out that the federal responsibility to provide for the direct care and public health services to American Indians and Alaska Natives. While it's on each of us to make our own decisions and be informed and responsible to the extent we're able to for our own well-being, for Indian people, So much has been taken, as we know and probably acknowledge, but the responsibility to provide for that health and well-being and care fell squarely on the shoulders of federal government. Now, over time, many Indian communities, through legal means, have been able to take over those federal responsibilities to provide their own tribal health programs. But before I don't want to get too far off track here. I just really wanted to mention, at the beginning, you talked about the disproportional impacts that COVID-19 is having on many of our communities. And in the American Indian Alaska Native communities, um, the disproportional impacts are, in my opinion, kind of deplorable. I mean, it's horrifying to see what is happening in so many of these areas. And all I'll say to that is, from my perspective, and from the perspective of many Indian people, with the passing of every member or descendant of our Indian nations, whether we reside on or off the reservation, live in rural or urban environments, every one of those lives matters very deeply and greatly. Because the reality is, we all are embodiments of the living memory of the earth and the sky, of the lifeblood and the everlasting spirit of the people. It's carried in our genetic code, is the seed of our future, the language, our songs, our ceremonies, our dances, our food, the life knowing of this nation's indigenous peoples. So to me, this is deeply personal work. And it's just really important to recognize that for many American Indians and Alaska Native people, not all, but there may exist some deeply inherent distrust and mistrust, many aspects of the social and civic life that are dominant in our current culture of America, for many, many reasons. But again, I just wanted to kind of bring this to our attention and just kind of help us recognize these sort of realities. Because again, it's in my opinion and my belief that it's up to all of us to really work to inform ourselves of the history of Indigenous people in America. Because I think collectively, I'll say this, I came through the same school system as many. We are kind of collectively robbed of much of our nation's history. Okay. So I just encourage us all to work in tandem and to further educate ourselves through dialogue and experiences like this to learn from one another, because that's where we'll find these solutions. Now, really to speak more to the point of COVID vaccines and tribal nations and how tribal nations and Indian people are obtaining some of these. And it's not a uniform answer, but in general, in the Indian Health Service, if you really kind of want to see the playbook, the Indian Health Service released their COVID-19 vaccine plan in November of 2020. And it was really developed and based on the CDC's COVID-19, their vaccination, the interim playbook for jurisdiction operations. So based off of that, Indian Health Services created their own vaccine plan and released that. Now, tribal health programs and urban Indian organizations were presented an option and issued a rather short notice by the feds to decide if they wanted to work through existing state and local health jurisdictions to obtain their share of the COVID vaccines as they became available, or they could choose to obtain their vaccines directly from the Indian Health Service. And that matters in certain ways, but once the vaccines are available, they're allocated to jurisdictions, including Indian Health Services, who then distributes them to Indian health programs and urban Indian organizations. Tribal nations played a key role in the planning of the vaccine rollout across Indian country, and so this is a continuing process. Just a few highlights and some touch points, and I'll get into some other details here. There was, let me see here, on January 14th, I believe it was 15th, right around there, about 340 IHS, Indian Health Service Direct, or tribal health programs or urban Indian organizations chose to receive their vaccines from Indian Health Service. The remaining, say, 230 health programs or urban Indian organizations chose to receive vaccines through their state and local jurisdictions. through my work, I'm finding that that's really an important thing to be aware of, because as we're finding, the plans that jurisdictions and the jurisdictional rollout and oversight is how these vaccines are distributed, um, it's kind of messy, and it seemed to really depend a lot upon those strength of those relationships that had existed prior to this. As we are all realizing, this pandemic has pointed out many weaknesses in our current ability to respond to this pandemic or any other pandemic. Um, so I just wanted to let you know that the tribes were given different options to receive their vaccines. And so depending on which option was chosen, that somewhat dictates how those vaccines are rolled out. Who's in the priority categories, how quickly it can move from one priority group to the next. So state and local jurisdictions have their playbook, and that script is kind of, it's there. Now, within tribal communities and those urban programs or tribal health programs that have chosen to get their vaccines through IHS, being sovereign nations, they have a bit more flexibility, if you will, to move and determine the pace that they go through the different categories for those to be vaccinated. They can also make some changes as to who they chose to prioritize. So it might not mirror necessarily the local or state jurisdictional rollout of these vaccines. They may choose to prioritize all their elders, age 55 and up versus the 65 and older, or 70 and above, or wherever states or local jurisdictions may have decided. So it's important to understand that there is some flexibility that tribes had that others did not. I don't want to get lost too far into that, but to the point of things to know about Indian people, and ways to possibly approach them. I mean, there's so much I could talk about. I'm kind of like, I'm stuck here for a bit. Like there's a lot of ways that we can really kind of support that. And I guess a few things that come to my mind, and when I was thinking about this is so much of it, it came down to just, we have to recognize that the reality is people make decisions based on values, often far more than they do on science, for better or for worse. I was looking at one recent survey indicated the majority of people that responded chose to get their vaccines to protect others in their family or other people around them that they knew were vulnerable. And I found that this was very not a value that seemed apparent or universally in alignment with many different cultures. And I look at our dominant culture in some ways, and I see some of the resistance to vaccines and to getting vaccinated. And to me, that's a very big cultural divide there. Do I do this on behalf of the others and other people in my community, or is this just about me? We all have to make those decisions, but there are those kind of nuanced cultural approaches that we face in making our individual decisions. Since a lot of our decisions around getting vaccinated or not, or other healthcare choices are really grounded in our cultural and community and personal values, communication can get really difficult. And there are so many subpopulations. American Indians, I think, might be one, seeing as we're only like maybe 2% of the population of the nation as a whole, would often be considered subpopulations, especially within urban environments. So we're often unseen, unheard, and not a lot is known. And we're so varied and widespread in our beliefs and practices and knowledge of history and traditions. And cities, more Indians live in cities than they do in reservations, due to all kinds of reasons. But communication was the first thing. It's not real creative, but communication was a huge piece. Trusted sources of communication are important, using official information to amplify those messages, being that central source of information for folks, and being consistent and concise and accurate, and repeating the messages, that whatever message we're trying to get out, that is just so critical in influencing people's behavior. And I don't believe what I'm sharing is anything necessarily new, but I just want to emphasize that when I'm talking to so many folks where I live, we have lots of immigrants and refugees and folks that are here, and there's so many gaps in knowledge and communication about just the basics the vaccine, who's eligible, is it safe, is there a cost to it, where do I get it, is COVID even real? I mean, there's so many of these messages that are being communicated and perpetuated that are coming from sources that are not necessarily the best, but they have great influences over people. So Indian folks are not necessarily any different than that, but I pointed out to say that we all have our own communication channels that we primarily rely upon. So trying to understand the coordination, the communication channel is a big one. I'd say coordination with what's already happening in your community. I can't emphasize enough the need to explore and understand, is there an urban Indian organization in your community that if you have individuals or families that are Native or identifying being American Indian or Alaska Native in your community, these urban Indian organizations could be a great resource to help connect you as an agency and or your clients to resources that might not otherwise be available through the traditional jurisdictional rollout. A lot of folks that are Indian might not have any idea that there is a satellite office for a tribe that they're connected to in their region. Also those urban Indian programs could serve anyone that's Native, if they identify it. There's certain criteria and they'll let you know if they can provide help or support there, as well as tribes that might be in the area, in the region. There are also great resources to reach out to if you're able to connect with them. Granted, a lot are shut down and during the pandemic and all, but there's a lot of partnerships that can be developed, I think, with tribes. Tribal entities are excellent partners. They have very robust health systems and they're very advanced in so many ways. And they are grounded in that whole person wellness and care and well-being, and likely have some means to support your work within your individual agency. Just real quickly, and last thing I want to say, unique solutions. I've had a chance to see a lot of really great things happening in tribal communities that I think are replicable elsewhere, setting up isolation and quarantine facilities, tiny houses, or like just units that are already kind of off the shelf by other companies that are creating these things, mobile medical units to get vaccines out, supporting people in their transportation needs, to get to the clinics or to get to a vaccination site, making sure that those people, if you are eligible to get vaccinated, have the accurate information, doing the work to coordinate that information to provide folks, hey, this is where you need to go. These are the hours. This is what you need to bring. No, there is no cost. Like getting the details together and providing that information is critical. I'm going to have to cut myself short here in a little bit for the sake of other presenters, but there's just so much that I wish I could get into now. But just I wanted to lastly acknowledge we all have our knowledge gaps, and sometimes they're large and sometimes they're small. And I don't want our knowledge gaps around American Indian people and Alaskan Natives to prevent us from feeling like we're unable to help or we're doing something wrong, or like just to let our own internal biases or stereotypes that we're all fed continually around Indian people to negatively impact our ability to work and support the folks that you're supporting. But I will just say that this, you are fully aware generational and historic traumas are real. They manifest themselves in so many ways. Many Indian people are carrying a lot of wounds with them that are unseen, that they're struggling and working through addressing. This is a collective challenge that we're all trying to get through. I'm going to have to stop myself here and hand this off to, I believe, Michele in a moment. But I just really wanted to say, it's really, I'm hopeful that through our collective and individual efforts that and our intentions to support each other, that we're going to continue to create healing and healthful communities and safe spaces to figure out how to approach these difficult challenges and maximize our unique and individual potentials and persevere, and survive and live through these trying days. Again, I just thank you for your attention. There's so much more I'd love to share. I hope some of what I said was useful. And that's really where I'm going to have to end my time and turn it over to Michele. Thank you.
Thanks, Ashley. That was all very helpful. And I appreciate you providing us with that just information that we may not have gotten before about how to work with tribal nations and how to support each other in the work that we do. So I'm Michele Williams. I'm a HUD technical assistance provider working on the vaccine distribution team, as well as I work with the crisis services in Hyattsville, Maryland, and we operate both homeless shelter and we're the lead victim services agency for the county. All of this work is really very close to my heart and a large part of my activities. I wanted to share with you all today just the steps that we're rolling out from a HUD perspective as to what communities and individual providers can do to ensure that the people that you serve and staff have access to vaccination. So we have framed up our work really in a set of steps, and I want to go through what we've identified kind of as the first 5 steps for communities to take. So the first is, if you have not read your state's vaccination plan, I really encourage you to do so that you can understand the framework under which your community within your state is going to receive the vaccine and who is prioritized into what groups. Congregate shelter providers are classified differently in every community. In my community here in Maryland, they were in 1B. So effective today, the staff of our programs and residents started receiving their first vaccinations. I received mine this morning. So things are happening, and understanding where you are in that process is really important. The second step is to work with your public health partner. And so while the state plan is, for the entire state, how things actually roll out in your community is determined primarily by your public health system. And so, as Ashley said, if you have a relationship, that's wonderful. If you don't have a relationship, start one now, and plan to continue and nurture it. One of the things that we found very helpful in reaching out to our public health partners to plan for how we were going to get program participants and staff vaccinated was being able to, negotiate a bit, right? We had different settings and different concerns. So for our domestic violence safe house, it was very important to us that we protect the people who are staying there. And so we were very concerned about them going to, my connection's that unstable. Can you guys still hear me? Okay, great. We were very concerned about them going to a mass vaccination site. So we were able to work with public health for them to bring the mobile unit to our safe house. And so the very first test of that is actually happening today as well. And it was the first use of that mobile unit for public health. So they were anxious to figure out how to make this work. And we were very anxious to have them come so that we didn't have to put people in a situation in which their safety or confidentiality may be of concern. So definitely that relationship is really important. For our homeless shelter, where we have more than 200 residents, we weren't really able to set up a unit, and that has a lot to do with the vaccines themselves, the temperatures they need to be kept at, and the length of time that a vehicle could be out. And so, we agreed to provide transportation for our residents. So we're going to run shuttles basically from shelter to vaccination, to the vaccination site for everyone. The other thing that you want to work with public health about is really assuring that there is priority access for your staff who are coming into direct contact with folks. It's really important as you try to increase the level of safety in your program that people are getting vaccinated kind of at the same time, right? Or in the same time period, right? Because that's going to help ensure better coverage. One of the things that we know as we move out into this process is that not everyone is comfortable with the idea of a vaccine, with getting a vaccine for themselves at this point, and that's okay. It's really important that we continue to provide good information, right? And opportunities for people to ask questions. to understand more about the vaccine, to have access to all the things that are in the media. And there's tons of resources now out on social media, good resources, not bad resources, because social media contains a lot of stuff. But there's certainly very reputable sources coming from the CDC, from other health organizations. I want to direct you all to the link in the resource section. We have a page on the HUD Exchange that is a vaccine kind of landing page, and we put out a weekly message with information and links for providers and flyers that you can download and post. And so all of those things we want to make available. We also link to a lot of other very valuable resources that we're finding that we want to make sure get shared out in communities. One of the major strategies that we suggest, if you're able, is to identify vaccine ambassadors. And vaccine ambassadors would be people who are either participants of a program or trusted staff, trusted community leaders who are supportive of getting the vaccine, who are willing to talk to people about their experiences, who are willing to answer questions, right, or direct people to places where they can get really good information. It's all really wonderful when, someone stands up and says, I'm getting the vaccine, but if I don't feel a connection to them, it doesn't sway me one way or the other, right? So in some cases, it sways me in the opposite direction. So really paying attention to kind of who is a trusted source in your community and how can we talk with those folks, and even, people who may be hesitant, talking about why they're hesitant. Conversation is the thing that's going to move all of this forward. And so it really is important that we support each other and engage in conversations. And I would say the thing that I think we're kind of losing a little bit, one of the things when the pandemic started, I think as we moved through it, we all began to extend to each other a level of grace. And I don't want us to lose that. So even though, there are folks who are really excited, myself included, that there's a vaccine and I want everybody to be vaccinated, I have to extend grace to people who are not ready. And so I really want to encourage us to continue to do that. It's really important that we build vaccine confidence, right? We don't want to have people jump into something that they're uncomfortable with. And so really providing that education, that person to talk to, the access to information is going to be really important. And so as you are working in your programs, that you're, having meetings, having opportunities to have people come in and provide expert information, to share their experience in getting vaccinated, all of those things are really important in building vaccine confidence for staff and for program participants. I want to just highlight on that when you go to the webpage, and I think we can actually send the materials that have come out so far. I think we have 4 messages actually out, a 5th coming this week. We encourage you to review those materials, to check out all the links, to go back to that, bookmark that page, because there's going to be a lot more information added to it. And we want it to be a resource for you. So you don't have to, struggle to find the answers to questions or to find tools. We even have go as far as to give you a guide for how to have a staff meeting, around vaccination. So please check out those tools whenever you have time. There's a lot there for you. And really familiarize yourself so that we approach this conversation with the people that we serve and with our staff in a really informed and appropriate manner. So thank you. And I'll turn it over to Ashley Marshall.
Thank you so much, Michelle and Ashley, for the amazing information that you have provided so far. So my name again is Ashley Reynolds Marshall, and I'm extremely thankful to join you all and for the work that you do. As a person who gets to support both domestic violence and sexual assault services at YWCA of Central Virginia, I'm always so grateful for all of the associations and organizations across our nation that work to provide direct and technical support to those advocates who are working to turn victims into survivors. I also happen to be an academic who focuses on the intersection of public administration, public policy, and nonprofit management on issues of diversity, equity, inclusion, and justice. I was provided with a very interesting opportunity this summer, summer of 2020, to work with a group of talented professors in the areas of history, folklore, and public health to produce a textbook that looks at a very unique subsection of COVID-19, which is COVID conspiracies. My work first focused on the clear conspiracies that specifically Black Americans may have believed. And second, I looked to provide context to some of the rumors and legends that Black Americans were having surrounding the pandemic. I always like to let people know that I use the term Black Americans versus African American because some individuals are not descendants of slaves who are here, but they are still as deeply impacted as anyone else. When we think about the work, so you heard me say conspiracy theories and rumors and legends. Well, what in the world is the difference? When we think about conspiracy theories, I'm sure everyone here just had one come to mind. And we typically look at those as an academic, as a way to explain an event or a set of circumstances as the result of a secret plot, usually by powerful conspirators. Whereas academics think of Black conspiratorial thought as a way to make sense of illogical conclusions and inconsistencies in official accounts based on centuries of evidence regarding Americans' relationship to Black citizens. Professor David Dennis created an interesting way to differentiate. He says that traditional conspiracy theories offer a way to escape from an inconvenient reality versus Black-focused conspiracy theories really look towards the historical touch points that communities of color may hold. Now, don't get me wrong. Of course, individuals of color can believe in what we think of as more traditional conspiracy theories. There are some Black Americans who think that rapper Tupac Shakur is still alive and living in Cuba. There are some Black Americans who believe that Michael Jackson really died in the 80s and who died recently was an impersonator. And rapper B.O.B., an NFL player named Sammy Watkins, and an NBA player, Kyrie Irving, have all publicly stated that they believe the Earth could be flat, with B.O.B. going the farthest as he has joined the Flat Earth Society as a member, and in 2016 created a pretty interesting diss track against astrophysicist Neil deGrasse Tyson, who certainly believes that the Earth is round. For Black Americans, however, and this includes both your colleagues, your staff, and your clients that you may serve, some beliefs, rumors, and legends really come from that residual trauma of actual historical prejudices and racist experiments since 1619. Typically, we see these rumors based on the historical devaluation of Black bodies. And I saw that someone in the chat mentioned Henrietta Lacks. That is an amazing one, but typically the one that most people think of is the Tuskegee Experiment. For individuals on the call who may not know, in 1932, 600 Black men, 399 of them who had syphilis, and 201 who did not have the disease, joined a study that was entitled Tuskegee Study of Untreated Syphilis in the Negro Man. The study was ran by the US Public Health Service. And what actually happened is that these individuals did not receive the informed consent that we see now. They were told that they were being treated for the disease, but that was incorrect. As a matter of fact, if they had some additional medical issues, cough, cold, anything like that, in their communities, the public health service told the doctors not to treat them. Because what the study really wanted to see was what happens to syphilis patients when they go untreated. The study ended in 1972, but keep in mind, it was only supposed to originally last 6 months. So remember earlier, Debbie touched on the issue of the percentage of Black Americans who have been vaccinated. So as of January 20th, Scientific American reported that about 3% of all Americans had received at least one dose of the coronavirus vaccine. But in the 16 states that actually released data by race, we see those clear inequalities. I know that Debbie mentioned in DC, one of the sort of largest barrier in space that we see is in Pennsylvania. So in Pennsylvania, as of that date, as of January 14th, 1.2% of white Pennsylvanians had been vaccinated, at least receiving one dose, while only 0.3% of Black Pennsylvania residents had received the vaccine. And then if we think about even earlier in April of 2020, as opposed to restricting the vaccine, there was discussion of maybe we should test on people of color. At that point, two French doctors who proposed to test on COVID-19 treatments in Africa because they believed that, well, Africans were highly exposed and they didn't bother to protect themselves. So this was a wonderful place to test any treatment. So when we think about these things, when we think about that history, we have to have a moment of understanding about maybe why our staff, our colleagues, our clients, and our loved ones may have a bit of hesitancy. So, we know that African Americans right now here in the US are not receiving the vaccine at an equal rate. And maybe we might want to say, well, that's because the first round was healthcare workers. But what we also know is that Black workers are 50% more likely to work in healthcare and social assistance industry, and 40% more likely to work in hospitals than their white counterparts. So it's pretty easy to see when we think of all of these data points, the historical trauma of events like the Tuskegee Experiment and now Henrietta Lacks, the current issues where there's certainly valid and actual news about disparities, we can see how that can create some vaccine hesitancy. So Michele just provided you with some really amazing tools to have these conversations with your team. But a really quick way to think about it is just making sure that we listen and give space for those thoughts first and foremost. Ashley provided also some context with our Indigenous brothers and sisters about that historical generational trauma that could be just under the surface as to some of their hesitancy. So we need to make sure that we legitimize these ideas. And then again, as I think all of us have stated, and Debbie stated as well, give facts. A lot of people are just nervous. They think that, for example, this vaccine, it's new technology. Well, it's a new vaccine, but it's not new technology. They've been working on this for many years. And so giving that kind of information and also talking about individuals of color who have had the shot. I always tell people that my mother, who has many different risks, has had both of her vaccinations as a healthcare worker, and she's fine. She happened to have no symptoms. And that actually has given solace to even some members of our family to go ahead and get the vaccine. So again, I just wanted to make sure that I'm very thankful for having the opportunity to talk about some of that historical frame of mind of vaccine hesitancy for communities of color that you're going to see, again, not only in your staff and your colleagues, but also in your survivors who are moving from certainly the trauma of domestic violence now into this moment of, can I trust Western medicine? So I appreciate the opportunity.
Thank you, everybody. Ashley and Michele. And Ashley, thank you so much for being with us today and presenting some incredibly valuable information. Gave us so much to think about and things that we should be doing in the field just to make sure that we minimize the trauma to individuals as they decide about vaccinations. So we do have a few questions, and I wanted to toss those out and see if you all might be able to help us. So we did have one, I think maybe Ashley Marshall, you were discussing this briefly, but just wondering if you might be able to provide, or any of you, some guidance around how to convince clients that might have been involved with that Tuskegee experiment on whether they should or shouldn't take the vaccine. I don't know if anybody wants to tackle that, but I'll toss that question out.
So I think it's very interesting. I think a lot of people are very much affected by the Tuskegee experiments. It's certainly something we heard about our entire lives, and so yes, it's a reason for us to have been skeptical. I think the things that Ashley Marshall mentioned about why this process is different are really important, and I think there's quite a bit of information if you actually Google that. That helps kind of explain, even an article I read from the family of a Tuskegee experiment survivor, you know, talking about why this process is so much different than then, and why they are encouraging people to get the vaccine. You know, I think it's not a matter of convincing necessarily. I think it's a matter of providing people information so that they can begin to feel comfortable.
And I would just quickly agree with Michele. It really is that provision of information. What I often see is that, of course, individuals will bring up Tuskegee. And then if I make the point that the issue in Tuskegee was that they were withheld from the opportunity to receive treatment, versus now people are encouraged when it is available for them to go get treatment, it sometimes makes people pause, because it is different. It's a very different situation, but also just recognizing that generational trauma that comes from the knowledge that Black bodies and Indigenous bodies have been used as a testing space by modern medicine. I think it's just really important that, you know, we don't kind of poo-poo that side of it, but we provide those facts about the fact that the vaccine isn't new, about the fact, as Michele just said, that even the survivors of the families of the Tuskegee Experiment are saying, no, please, if you are willing, if you are able, if you are not medically compromised, go get the vaccine. All of that helps people at least have this kernel of knowledge that is slightly different, because we all, unfortunately, now are in a bit of an echo chamber. So typically, if you're someone that's a little nervous and afraid of something, what are you going to do? You're going to WebMD yourself, which we all know is the worst thing that you can do. But if that's all you're hearing are things that are just reinforcing your fears, one of the ways that we can be really supportive is by saying, you know, I recognize that you're really nervous about this and I understand, but hey, I heard this. And then you are just breaking into that echo chamber in such a loving way. That doesn't mean they're going to take your advice, but that does mean you've given them something different to think about.
I just want to, yeah, real quick, again, the information that it is critical. And just wanted to point out organizations like National Indian Health Board, John Hopkins, American Indian Program, there's a number of resources specifically geared towards American Indian folks as well. And the point about finding the ambassadors is critical. And I say, if you explore tribal websites, go to their newsletters or newspapers, you will find so many great bits and gems to share as far as encouragement and around safety and helping and make informed decisions. So I'll add.
Thank you all. You're just such a wealth of information. Really appreciate your being here with us today. We have a few more questions. I know that we had a question, and I think this has come up a couple of times. Just wondering about the question of making the vaccine mandatory or not, especially when communities and public health are talking about the herd immunity and trying to get the collective community to that level. Could any of you address the aspects of mandatory vaccines, whether that should be something that victim service providers specifically require or not?
So I can take this one. Our organization, the YWCA, we have a voluntary vaccination policy that we strongly encourage our staff to consider being vaccinated. We, of course, will recognize the ADA and civil rights opportunities to request for accommodations, either for medical reasons or for religious reasons. Even though we have a voluntary policy, we have put paperwork in place just so that we can have it in the team members' file, should we ever need it, should something go wrong. And in our voluntary policy, it does say that if you are unable or choose not to get the vaccine, you may be asked to wear a mask, maybe even a little bit longer, because I know that the science is still moving as far as the area and other options. What I normally have seen is if there is an organization that already has a mandatory vaccine policy, you could think about it. I have also seen individuals who traditionally have a mandatory vaccination policy, such as hospital systems, having this vaccine to be voluntary. And so while the law is a little muddy, if I had a organization that had a mandatory vaccine policy and I was thinking about this particular vaccine, what would give me pause is if major medical and hospital systems are leaving it as voluntary and they traditionally have mandatory practices, they usually have more high paid lawyers than I would. So I sort of take that into consideration. If you or any member of your team is a member of SHRM, I think there's some really great HR resources there, because I know running a nonprofit, we don't normally have lawyers on staff who do this work, but SHRM is not going to release anything that would get anyone HR-wise in trouble. So I would look to the guidance. If you really want to make it mandatory, that is when I would tell you spend the money and reach out to an employment law attorney to get their take on it. The law is continuously evolving on it. EEOC regulations, OSHA regulations are just revolving or, continuously changing about this. So I would definitely consult an attorney if either A, you want to make it mandatory and you have a mandatory policy. Definitely if you want to make it mandatory and you've never had a vaccination policy before.
Great, thank you, Michele. I think that's wise, especially if when you're in doubt, spending the money for an attorney might be incredibly valuable at this particular juncture. I did want to tack off to a question that was asked, because I think it's come up a couple times related to the vaccine. We do know, and we're hearing in the media, that the COVID has mutated, maybe even a couple of times. Since there's really not a lot of data at this point, would anyone be willing to talk a little bit about whether the vaccine will help people with the various mutations, and also just in terms of helping people make informed decisions around getting the vaccine and the long-term effects? If there's anything anybody would want to share on that, love to hear your input.
So I will share. I'm not a medical provider, though. I need to say that very specifically. So I'm only watching the news that continues to come out about those variants, and I think Dr. Fauci actually made a statement today on that. But I think one of the things that we do know about the current strands is that they can be very deadly, and so, as we're trying to figure out all of the new strands, for me, the risk of getting COVID is more scary to me than the potential. So if I had a limited amount of protection, I think that's what I'm seeking. Just in full disclosure, I had COVID. My husband and I both contracted COVID in December, and fortunately had very mild cases. I know that's not the case for everyone, and so I worry tremendously about a second round at it. In terms of contracting again, it's not a risk that I felt comfortable taking. So I don't know. I don't know how viruses mutate. I don't pretend to understand the science, but I do know that for myself, I want to have protection.
Great, thank you, Michele. Appreciate your sharing that. Let's see, we might have time for maybe one or two more questions. I did want to mention we will make the slides, and I believe the chat notes available to everyone. We'll be sending those out in a few days. So I know we've talked fast and furiously, so we'll be sure to share this information with you because it's just been really amazing. Let's see, we did have a question on policies. If anyone had any sample vaccination policies that they could share. Do any of you have those that you'd be willing to share?
I would be happy to share mine. And just like Michele, my caveat is I went to law school and then I ran. So I have a law degree, but I do not practice. But I shared our policies at the YWCA with our Action Alliance in the Commonwealth of Virginia. And I'm happy to share with anyone else who would like to see them and use them or send them to their lawyer, whichever you would like. And remember, mine, though, are all voluntary. I do not have a mandatory one.
Great. Thank you so much, Ashley. I also wanted to just mention that somebody sent to us an answer around the mutation question. And if I can hold on to it long enough, I'll just read it. The vaccine does not contain a live virus. It contains a protein that the virus also has. That protein is how it attacks the human body. As long as that protein is present in the strain, meaning the mutations, the vaccine should be effective on those strains. So that's all that any of us know at this point. That just sharing that information. And if you have any other questions, feel free to reach out to us. I think we are at the top of the hour, so this will conclude our webinar for today. And just again, want to thank both Ashley's and Michele for being with us and presenting such incredibly helpful information. Thank you all for joining us. We look forward to joining you in the near future on future webinars. Have a great day.